Hi, I'm Gail Ferguson, and I'm a pediatrician in the Buffalo area. I have been working at Neighborhood Health Center, which is a federally qualified health center in the northwest area of Buffalo for the last 25 years. I've been asked to talk to you today about the diagnosis of failure to thrive in pediatrics. Honestly, we see this all the time, so it is a very relevant subject. Um, So let's start at the beginning. What do you do when you walk into that room and you see the growth curve? You need to look at your growth curves every visit. And when you look at that growth curve and you see the weights dropping off the curve, you need to be taking a really good history. You've heard it before, I'm sure, that you can make 95% of your diagnoses on history alone. This is accurate. This is why telehealth works, right? You can't see those rashes very well on telehealth, but you can take a really good history. So, what are you trying to weed your way through when you're dealing with a patient with failure to thrive? Number one, is it inadequate calories going in? Or is it inadequate calories being absorbed? Or is it too many calories being lost for some reason? Or is it increased nutritional requirements? Do they need more calories than they can possibly consume? And that's how you're going to build your differential diagnosis, is by thinking about all of those things. So like I said, history taking is crucial. You want to get a good feeding history. You want to get a good history of symptoms. Have they had fever? Have they had abdominal pain? Are they throwing up all the time? What do their stools look like? Then this is what your whole entire presentation today is about. But for me, I want to talk about what do we actually see in the real world. So I think what I find to be the most important is to take a good social history. I've learned a whole lot about zebras in my life, and I've seen a few zebra diagnoses in children with failure to thrive over the course of my career, but it's a few. And mostly what I've seen is patients aren't able to get enough calories in, whether that's because the food isn't available, whether that's because the parents don't know how to feed the patient, whether it's because a mom has depression and doesn't have it in her to actually feed this patient who is crying and begging for food. I remember very, very specifically a patient where I walked into the room and there was this cachectic little 2-month-old who hadn't gained any weight since I had seen them at the 2-week visit. And the baby was on the exam table crying. All this baby wanted was to eat, and the mom was sitting there with a bottle at her side, but not able to give it to this patient for some reason. So asking very detailed history on how this patient is being fed, when this patient is being fed, how they're mixing formula in the babies. This is very important as the child grows towards the age of 2 and parents are inexperienced and children become fussy. They don't want to the patients start refusing to eat solids, and all they want to do is drink, and they love their milk and they love their juice, and so they spend their day drinking, and they never get hungry. These are honestly the most common reasons that I see failure to thrive. And in those patients who are drinking just milk all day, 40 ounces, 50, 60 ounces of milk in a day, you're also going to see some pretty significant anemia and perhaps heart problems. So those patients end up with hemoglobins of 6, and it's crazy. So those are the big things in the young children. And the first thing I would do with a young child is take that good history. If they go home and they come back in a couple of days and weight gain isn't improving, but they're looking okay, and I send them home again for a week and weight gain is still not improving, then at some point you do need to do a bit of a workup. And you're going to start by doing like basics. They're going to tell you, are their kidneys working okay? I'm going to get a complete metabolic profile. I'm going to get a CBC. I'm going to get a SED rate and a C-reactive protein. I'm going to get a urinalysis, and I'm going to get a urine culture. And then once I get those results, if they're still not growing, you need to start. You're going to see a little bit if you need to be thinking about other things. Do you need to be thinking about endocrine, any inborn errors of metabolism? But good history, good physical exam, you're going to go far. Most often what you'll see is a healthy looking baby who's just not hitting on the growth curves. If there's, trust your instincts. If they look sick, if they're wasting, you're going to do a more thorough workup much more quickly. Then, if we start thinking about older children, it's the same thing. You want to think about the same things. Are there enough calories going in? Are they restricting themselves as you get into the older children and adolescents? You need to start thinking about eating disorders. Or are there increased losses, or like an inflammatory bowel disease would be a good example of that, or increased nutrient requirements for some reason. So again, a good history goes a long way. Is there depression? Is there anxiety? Is there an eating disorder? But also thinking about other things. And I'm going to tell you actually a personal story about this. My oldest daughter, has been diagnosed with adrenal insufficiency. It took us almost a year and a half to get that diagnosis. And the problem was she was a late teen. She was in her early parts of college. She was losing weight tremendously. She lost 30 pounds in the course of 6 months without trying, and was actually trying to gain weight. And the doctors didn't believe her. And so everybody thought she had an eating disorder. Every doctor that she went to thought that she had an eating disorder. She had massive workup. She ended up at a GI specialist, and it took a time when she made dinner for me and I couldn't eat it because it was so salty and she didn't taste the salt in it, for me to go, huh, I'm worrying about adrenal insufficiency in you. And even from that point, it took another 3 months to get the diagnosis, and a hard time getting any of the physicians to listen to her because they were so set in their particular field. A GI specialist isn't going to think about that. Her primary care, because it was adrenal insufficiency and difficult to prove on laboratory, they were listening, but they didn't know what to do. So finally ended up at the right place with the endocrinologist. But please, please listen to your patients, because they will tell you the story, and you need to ask the right questions, because I knew what I was hearing when she told me that she liked that salt and I literally couldn't eat that salt. I knew what I was seeing when my fair child was really tan for a summer when she wasn't spending that much time outside. These were all signs, and if you don't know what you're looking at, you have to have somebody ask those appropriate questions in order to get at the right diagnosis. And the really scary thing for her is that was life-threatening. She did not have the right medications, and there were several occasions when I look back now, she really could have died because she was in crisis and no one knew what the crisis was. So please ask all the questions and take really good care of your patients, no matter what your complaint is. That's the best advice I can give you as you start your careers, is always ask the next question. Good luck with everything. Bye-bye.